Renal tubular acidosis (RTA) is a renal disorder. Look at this picture, shows that kidney glomerulus. Look at this. A detail going on. Introduction. Renal tubular acidosis is a group of disorders characterized by a defect in the renal tube ability to maintain acid base balance despite normal glomerular function. The kidneys fail to properly excrete acid or reabsorb bicarbonate, leading to metabolic acidosis. Definition. RTA is a medical condition in which the kidneys fail to excrete acids to the urine, leading to a chronic metabolic acidosis with a normal anion group and preserved glomerular filtration rate GFR. Etymology. The term renal tubular acidosis comes from Latin Greek root renal Latin renalis meaning kidney. Tubular refers to the kidney tubules and acidosis Greek echoes for remedy plus osis indicating a condition. Here meaning increased acidity in the blood. Together the term describes a condition where kidney tubules fail to regulate acid levels, leading to systemic acidosis. Epidemiology. Renal tubular acidosis is a relatively rare disorder with an estimated prevalence of 1 in 100,000 to 1 in 200,000 individuals, though exact rate vary by type and population. It is more commonly diagnosed in children with inherited forms and in adults with acquired forms due to autoimmune or metabolic conditions. 1. Type 1 distal RTA. Impaired hydrogen ion H plus secretion in the distal tubule. Urine pH more than 5.5, often associated with nephrolithiasis and hypokalemia. 2. Types 2 proximal RTA. Impaired bicarbonate reabsorption in the proximal tubule. Urine pH initially more than 5.5, later less than 5.5, often linked with Fanconi syndrome. 3. Type 4 hyperkalemia RTA related to aldosterone deficiency or resistance, reduced ammonia excretion associated with hyperkalemia and mild acidosis. Note: Type 3 RTA was once recognized as a combination of type 1 and type 2 in children, but is now largely obsolete. Causes: type 1 autoimmune disease, example Sjogren syndromes, hereditary amphotericin B toxicity. Type 2 caused by Penicoin syndrome, multiple myeloma, carbonic anhydrase inhibitors. Type 4 caused by diabetes mellitus, Addison's disease, NSAIDs, ACE inhibitors. Risk factors: 1. Genetic predisposition, especially for type 1 and 2. 2. Autoimmune diseases. 3. Chronic kidney diseases. 4. Use of nephrotoxic drugs. 5. Diabetes and adrenal insufficiency. Complications: 1. Growth retardation in children. 2. Osteomalacia or rickets. 3. Nephrolithosis, kidney stones. 4. Chronic kidney disease. 5. Muscle weakness due to hypokalemia. Pathophysiology. Here is step by step detailed pathophysiology of renal tubular acidosis, covering the major types and how they disrupt normal kidney function and acid base balance. Pathophysiology of renal tubular acidosis. RTA result from deficits in renal tubular function that impair an secretion or bicarbonate reabsorption, leading to non-anion gap hyperchloremic metabolic acidosis. 1. Normal acid base regulation by kidneys. Brief overview. Proximal tubules reabsorbs 85% of filtered bicarbonate. Distal tubules and collecting duct secrete hydrogen ions and generate new bicarbonate. Ammoniogenesis involves the production of ammonia to buffer in urine. Type 1 RTA, distal RTA. step by step process. 1. Defect in hydrogen ion secretion in the distal nephron. Collecting ducts. 2. Urine remains alkaline, pH more than 5.5 because H plus cannot be secreted adequately. 3. Systemic acidosis develops as hydrogen ion accumulates in the blood. 4. The inability to acidify urine reduces excretion of acid load. 5. Potassium is lost in exchange for sodium, leading to hypokalemia. 6. Calcium is released from bones to buffer acid. Bone demineralization. 7. Calcium phosphate precipitates form stone in the kidney. 8. Chronic acidosis leads to growth retardation in children and osteomalacia in adults. Type 2 RTA, proximal RTA, step by step process. 1. Defects in bicarbonate ICO3 reabsorption in the proximal tubule. 2. Excessive bicarbonate loss in urine causes metabolic acidosis. 3. The distal tubule may still secrete hydrogen ion excessively, so urine pH eventually becomes less than 5.5. For low bicarbonate in blood reduces puffing capacity to acidosis. 5. Sodium and potassium basting acquired with bicarbonate to hypokalemia. 6. Often associated with Fanconi syndrome leading to glucosuria, aminoaciduria, phosphaturia. 7. Results: impaired bone mineralization, rickets in children, osteomalacia in adults. Type 4 RTA, hyperkalemic RTA, step by step process. 1. Deficiency of aldosterone or resistance to aldosterone action in the distal nephron. 2. This impairs Na plus reabsorption and K plus and H plus secretion in the collecting ducts. 3. Reduced hydrogen ion excretion leading to acidosis. 4. Decreased ammonia production reduces buffering of urinary H plus to less acid excreted. 5. Potassium accumulates in the blood causing hyperkalemia. 6. Mild to moderate acidosis develops urine pH may be less than 5.5. 7. Often associated with diabetes mellitus, adrenal insufficiency, or tubulointestinal disease. Common end results in all types: 1. Failure to maintain acid base balance, 2. Development of normal anion gap, hypercaloremic metabolic disorders, 3. Electrolyte imbalances, hypokalemia or hyperkalemia, 4. Long term complications like nephrocalcinosis, bone disease, and growth failure in children. Signs and symptoms: 1. Fatigue, muscle weakness, 2. Growth failure in children, 3. Polyuria and polydipsia, 4. Rickets and osteomalacia, 5. Kidney stone, especially in type 1, 6. Nausea, vomiting, 7. Arrhythmias due to potassium imbalance. Medical diagnosis: A laboratory test. 1. Serum electrolytes low, bicarbonate normal, anion gap. 2. Arterial blood gas, metabolic acidosis. 3. Serum and urine pH more than 5.5 in type 1. 4. Urine anion gap. B. Additional test: 1. Ammonium chloride loading test, type 1 diagnosis. 2. Fractional excretion of bicarbonate, type 2. 3. Hormonal assay: aldosterone, renin for type 4. Nursing diagnosis: 1. Impaired urinary elimination, 2. Risk for electrolyte imbalance, 3. Fatigue related to metabolic acidosis, 4. Risk for impaired growth and development for pediatrics. Medical management: 1. Correct acid base imbalance, 2. Maintain electrolyte balance, 3. Treat underlying causes, example autoimmune disease or infections, 4. Monitor kidney function, 5. Use of bicarbonate therapy. Nursing management: 1. Monitor vital signs and lab values, 2. Administer prescribed medications, example sodium bicarbonate, 3. Educate patient on dietary management, 4. Ensure fluid and electrolyte balance, 5. Observe for signs of metabolic imbalance or complications. Treatment options: 1. Sodium bicarbonate or citrate, correct acidosis, 2. Potassium supplements for hypokalemia type 1 and type 2, 3. Thiazide diuretics to reduce bicarbonate loss. In type 2, 4 fructocortisone or aldosterone analogues for type 4. 5 treat underlying conditions, autoimmune therapy, stopping nephrotoxic drugs, psychosocial medicine. 1. Patient education, improve understanding of chronic nature and management of RTA. 2. Nutritional counseling, balanced diet to manage electrolyte and prevent stone formation. 3. Support groups, especially helpful for families of children with RTA. 4. School support services for children with growth or learning issues due to chronic illness. 5. Mental health counseling, address anxiety or depression related to chronic health issues. Prevention. 1. Early diagnosis and treatment of risk factors, example autoimmune diseases, diabetes. 2. Avoidance of nephrotoxic medication. 3. Adequate hydration. 4. Regular monitoring of acid base status in high risk individuals. 5. Genetic counseling for inherited forms. In conclusion, renal tubular acidosis is a potentially serious yet manageable condition affecting acid base regulation in the kidney. Early detection, appropriate management, and supportive care are vital to prevent complications and improve quality of life. Multidisciplinary care involving medical and psychosocial support ensure holistic management of RTA. Thank you. Have a nice day.